Welcome, and it's a great honor for us to have Robert Bartlett here from University of Michigan, and he is really the doctor of ECMO in the world without question. And I had the opportunity to visit his lab in 1989, and that was really the best times of my life. Thank you, and really welcome.
Thank you, Polly, and it's such a treat to be here with this group. I have so many good friends here over the last 20-some years that I've made, and many of you have come to the ELSO meetings, or we've been at other meetings together, so it's such fun to come to your place now to see you. As you may not know this, but this is the best ECMO unit in the world. You have the best results of anywhere in the world. It's quite remarkable. And soon, well, right now you have the only dedicated ECMO ICU, but tomorrow you will have a beautiful new ECMO ICU that is unprecedented. You will have too many visitors here from everywhere to come to see how you do it. So it's a great treat for me to be here at the time that you're opening your new unit. I certainly wouldn't miss it. Well, to talk to all of you about ECMO is not really necessary, because as I say, you do it, you see the patients, you work with Polly, you work with Bjorn and Inga, and you are seeing the best of the best. But Polly asked me to say a few words about the history, how we got here, much of which you've heard before, but we can recount it again. A bit about where the technology stands now worldwide, and then a few words about where we think this will go in the future. So some of this information is for people who don't know anything about ECMO. Of course you do, but this technology, the term ECMO is not a very good description, is it, for what we do, because we do a lot of stuff other than oxygenation, and I personally prefer extracorporeal life support, or ECLS, as a term, but that's 4 syllables and ECMO is 2, so we usually stay with ECMO, and everyone understands that. What it refers to is a supportive heart or lung function with mechanical devices, which is temporary, days to weeks, now we would say to months, thanks to Polly and others, can be partial or total support. Most importantly, avoids ongoing iatrogenic injury. We can stop injuring the lungs with the ventilator, we can stop driving the heart and the metabolism with vasoactive catecholamines, and let those organs rest and then recover. And it sustains life, meaning keeps the brain going, while bridging to organ recovery of the heart or lung, or nowadays replacement. Well, I said we would talk a little bit more about history than we usually do when we get into this, but since all of you are actively doing this, you might find some of this interesting. There were 3 different groups that started developing this technology in the early 60s. Ted Colabo and Warren Zapol, who were at the NIH in the States, a man named Donald Hill in San Francisco, and our little group that began in Boston. This is the surgical staff at the Boston Children's Hospital. This is Robert E. Gross, arguably the most important surgeon of the last century. Now, one of his close friends was Clarence Crayford, who you might say was the most important surgeon of the last century, and you're allowed to, that's all right. But a marvelous man, very creative. So the surgical staff is here, the chief residents are here, the junior residents are here, and this is your speaker in 1965 as a resident with Dr. Gross at the Children's Hospital. This is Alan Gazzaniga, who was a resident with me, and he and I worked on ECMO in the very early days, and I'll tell you more about that later. This was the very early days of cardiac surgery, and most of it was done in children, and the complicated operations for tetralogy or transposition had a very high mortality. 50% of those children died. And the residents who did all the work here in the back row looking after those patients knew that if we could just keep those children alive for a couple of days, they'd be all right. Nowadays, we recognize what we would call myocardial stun. It used to happen a lot. We didn't have a name for it, but we just knew it didn't last very long. And so I was bold enough to go to Dr. Gross and say, why don't we just keep these kids on the heart-lung machine? I mean, they've been on it for the operation. Let's use it for a few days. Well, he said, of course, that's ridiculous because the machine is lethal in about 2 hours, which it was. But why don't you work on it? So we went to work on it. Well, we discovered, as did others, the cause of that problem had to do with bubbling oxygen through the blood, which is how the artificial lung worked. And it came at a time when silicone rubber had just been discovered. It was a unique plastic that allowed oxygen and CO2 to be transferred. So we set out to build what became known as a membrane oxygenator. And I worked with an engineer named Philip Drinker, who's here. And he and I worked on this. We built a membrane oxygenator. This is it over here. And what we learned is you could use it for a long period of time. This dog had been on extracorporeal circulation for 4 days at the time, quite unprecedented. And we learned from that experience how to maintain cardiopulmonary bypass for a long period of time, meaning a few days of time. We had to develop a device to measure what we called activated clotting time because we were using heparin, but very small amounts of heparin. We had to develop a controller to control the roller pump so it didn't suck too hard on the atrium and so on. But we developed this system. In 1970, I moved to the University of California at Irvine, a brand new medical school. Alan Gazzaniga and I continued that research, and this is from a paper from 1971. What it showed really was we could put animals, in this case sheep, on bypass for days at a time without any deleterious effects. So that was pretty exciting at the time, and it made us think that you might even try to hook this up to a patient at some time. Well, in fact, that happened in 1971, and the first person who did that was Don Hill from San Francisco, a cardiac surgeon. And this is the very first ECMO patient who recovered and ultimately survived. This is a young man who was in a motorcycle accident. He had a ruptured thoracic aorta that was repaired, but he wound up with what we would now call ARDS, and was attached with veno-venous bypass to this device. This is the Bramson membrane oxygenator. It took about 12 hours to assemble it. A sheet of silicone rubber, a spacer, another sheet that would break, throw it away, put a new one in. But once you got it put together, it worked as a membrane lung, and this man was on ECMO, we would now say, for a day and a half, and ultimately recovered. The first patient that we had that was successful was a post-op cardiac patient, the very problem we set out to solve in the first place. This was a little boy that we'd operated on. He had transposition of the great vessels, and we did a mustard operation. There are a few people here who know what a mustard operation is, but it was a pretty good operation, as a matter of fact. But post-op, he was acidotic, cold blue fingers, and no urine output, and had that syndrome that we had been very familiar with. So we took our machine that we'd been using in the animal laboratory and brought it over to the hospital and hooked up this boy to VA bypass, and he ultimately recovered. This is a picture of him a couple of years later. For the cardiac surgeons, I always point out that he had a good result from his mustard, and he still has 30 years later. In 1975, Al Gazzaniga and I were asked to see this little girl in the neonatal ICU. we, at the time, we were the pediatric surgeons as well as the general surgeons, trauma surgeons, ICU surgeons. We did everything in this hospital. So it was not unusual to get called to the neonatal ICU. And this little girl was, as you can see, a full-term baby, apparently healthy, with terrible lung disease, which looked like meconium aspiration, turned out later to be a little meconium, mostly pulmonary vasospasm or persistent fetal circulation. At any rate, she was dying. And they said, would you like to bring your machine over? Now, we had done that before without success in babies, but we cleaned it up, brought it over from the laboratory, hooked up this child using methods that we developed in the laboratory, in this case, veno-arterial bypass through vessels in the neck. And she ultimately recovered and became the first neonatal survivor. The access, as I say, was right atrium through the jugular vein, draining blood out, pumping it through the membrane lung, back into the aorta. Familiar stuff to you now, but pretty wild at the time. We're ligating the jugular vein, ligating the carotid artery. Now, we knew that would be safe, but still, it was pretty radical. Most neonatologists thought this was crazy. Why would you ever want to do that? But we had this patient, then we had another, then we had another, and over time, we treated about 40 babies with quite good results. Looking back on it, it's because, as you all know, babies that have respiratory failure, there are only a few causes. They almost all get better in a few days. So it was just happened to hit the right patient population to start with this technology. But it did work quite well. This represents the number of centers involved with this research over time and the number of patients here. In 1980, I and the project moved to the University of Michigan, where most of the development has happened, and we continued laboratory studies. We did multi-center randomized trials. We held seminars. We established a registry, and that led to the establishment of ELSO in 1989. I'll tell you more about that in a minute. So that's kind of how the early days went. And as other medical centers and people heard about this, most people, as I say, thought it was crazy. A few people thought, well, maybe we should find out what they're actually doing there, particularly neonatologists. So a few neonatologists and pediatric surgeons came to see what we were doing, went home, set it up, learned to do it themselves, and that led to progressively more and more cases and more centers being involved. It gets us to about where we are now. So the indications for doing this then and now are easy to describe in adjectives: severe cardiac or pulmonary failure not getting better with all the rest of the treatments, in which you might expect recovery. We used to say in 1 week, then in 2 weeks. Now we say in 2 to 4 weeks. Now we don't know what the time limit is. We've learned mostly from all of you that patients will recover when their lungs are destroyed for a month and still get better after that. But that's the indication. It's easy to describe it. And most big hospitals that have big ICUs, either babies or children or adults, will say, we only see 3 or 4 patients a year that are like that we can't get better with conventional treatment. Absolutely right. That's the way it should be. But if you take 2 or 3 patients in each of 100 big hospitals, you wind up with a lot of patients who die from ARDS or neonatal respiratory failure. So this technology, as all of you well know, applies to cardiac failure or respiratory failure or the combination of the two. And the machinery and hooking the patient up and getting it running is only a small part of the technology. Much more important is what all of you do, learning how to manage patients who don't have to breathe, whose heart doesn't have to work, and to understand the physiology and manage them on this machine until their native heart and lung can recover. I showed you picture of veno-arterial access. This is veno-venous access, as it has been practiced most of the time, draining blood from the inferior vena cava, pumping it back into the right atrium so that the blood pump is in series with the native lungs, not in parallel. So all the pumped blood goes through the lungs before it goes out into the patient. And that has certain advantages. It leaves the patient dependent on their own normal hemodynamics. We measure the things in the yellow boxes and use that information to control the circuit. Nowadays, we do the same thing, usually with the double lumen cannula, where we drain from the superior and inferior vena cava and reinfuse into the right atrium, but it's the same principle, an artificial lung in series rather than in parallel with the native lungs. So in 1989, we had been giving courses on how to do this for those few brave people who wanted to try to learn to do it and didn't mind getting up at night and using their holidays to take care of patients. And we combined that activity into a group that was called ELSO. This is the first ELSO meeting in 1989. I don't know if any of you were there. You weren't there, Polly, because you came later. But at any rate, the ELSO group has been quite important ever since that time, and I'll tell you a lot more about what ELSO is doing in a minute. So this is 1989. Also in 1989, I got a call from a young Swedish pediatrician who's sitting over there who said, I want to come see what you're doing, and I want to come long enough to see what's happening. Now, ECMO was not unknown in Sweden before that time. In fact, there was a group called SAFE, the Scandinavian Association for ECMO, which was started actually in 1987, very early on. And it was started by this man, Jostra Mellgren, who many of you know, pediatric surgeon from Göteborg. And he, like all pediatric surgeons, was taking care of babies with diaphragmatic hernia. Many of those babies died, and he thought we should set up an ECMO program for that problem. He invited friends from around the world, and the best part of the meeting was the sailing, which we really enjoyed. This is me and Jostra sitting on a rock over in the archipelago. And Mellgren's a wonderful guy. Many of you probably know him. He could never get the program started. The other docs he was working with, the neonatologists, pediatricians, they said, that's crazy, you don't want to do that. So, fortunately, this guy came to visit us. This is Polly Palmer, 1989, and Polly and Annika and their kids were over at our house for Christmas in that year. So these are a few pictures from then. But Polly came to work in the lab and in the clinic and helped to take care of patients and learned a lot about what we were doing. This is Annika, you probably know. This is Oscar, who's sitting over here. And my wife, Wanda, who's sitting over there. Oscar looks a lot older. My wife looks just as young as she does there. So. And this is Anna, their other little girl. So it's always fun to see them. We've been back to Sweden many times. There was a branch group from ELSO called ESO, the European Extracorporeal Life Support Organization, that met for 3 or 4 years. It died away. It's starting again this year. So next year there'll be the first meeting of the new version of ESO. But this was at Bjorn Frankner's cottage, and one of the treats for me is to get to meet the team in these various places, and of course getting to meet Inga, which is always a special treat. Here's what else happened there. So Bjorn has a sauna, and the drill was, of course, you know this, but this was kind of new to us. You got really hot in the sauna, and then you ran out and jumped in the ocean. Now, the ocean's cold, I discovered. So here's a group of us who were enjoying that activity. They say we've been back many times. One of my interests is medical history, and I for many years took a group of Michigan medical students on a medical history trip, and in 2003 we visited here, and this is the dissecting room in Uppsala. Many of you have probably been there. This is Polly and myself and some of our students. This is Jorn Heidensterna, who's one of the great experts in lung physiology and anesthesiology. So we've had marvelous times in Sweden every time we come here, as we are today and tomorrow. So ELSO has grown over time. It's been going 22 years now. These are the ELSO centers. There are about 200 of them around the world, major medical centers that use ECMO routinely. And ELSO, among other things, maintains the registry of cases, which is fairly complete. So to date, there have been some 46,000 patients in the registry, of whom 34,000 survived, and you can see the results in each category: neonatal respiratory, cardiac, or pediatric respiratory cases, and the survival rate for, these are all patients in the registry, goes from a low of about 29% for cardiopulmonary resuscitation in adults to about 75 or 80% for newborn infants. And I'll tell you a little bit more about each of those categories. It's been very interesting to see what's happened over time. This is the last 2 decades of ECMO cases in the registry. So as you can see, in 1990, all through till about 95, it was almost all newborn infants because the results were so good in that particular age group. Then over time, we used it less in newborns. I'll tell you about that. So now the newborn infants account for about 20% of the ECMO cases in 2011. Then there are pediatric respiratory failure, adult respiratory failure, and then cardiac cases. So except for this flu epidemic, which is right here, the largest use of ECMO nowadays is for cardiac support, usually for pediatric cardiac support, where there's no other machine that's easily deployed. There's no balloon pump, for example, or short-term VAD for children. I'll tell you a little bit about each of those groups. In the early days, almost all the cases were newborn infants. And what happened here was we realized that the good results in children was partly because they lived a couple of days longer, but also because the treatment at the time for pulmonary hypertension in children was killing children. Now we know that. Very high pressure, very high oxygen ventilation with the intention of hyperventilating till the pH was about 7.6. Some babies would open their pulmonary vasospasm, not many, and we killed a lot more babies in the process. But with these results with ECMO pointed out, ECMO doesn't treat anything. It just keeps people alive, but it made us realize that banging away at the lung in these babies was causing a lot of problems. We stopped doing it. We didn't need ECMO very much anymore. And then here in the middle 90s came nitric oxide and high-frequency oscillation. Inhaled nitric oxide, as you all know, has been used for all sorts of applications, usually with no beneficial effect except for newborn pulmonary hypertension, where it works beautifully. So nowadays it's pretty unusual, as you know, to get a baby who's failed with general ventilation, then failed with nitric. Those are pretty sick kids. This is a survival rate by type of diagnosis over time. This is meconium aspiration, and I remember the first case in Sweden. Polly would probably remember this because he was describing what we were doing and other people were doing, and said, we're treating a lot of meconium aspiration. All the Swedish obstetricians and pediatricians said, that's crazy. We see that problem. Those babies always get better. It's just never a problem. So about 2 months later, I remember Polly called me up, said, well, we're doing our first case, meconium aspiration. Sure enough, there were those cases. And they do get well in a hurry, as you know. Other pediatric diagnoses with good results pretty much across the board, considering that the alternative is 10-20% survival rate, all except for this. This is getting worse over time, and this is congenital diaphragmatic hernia. Now, the reason these babies go on ECMO is not because they have lung disease, it's because they don't have enough lungs. They have hypoplasia, and what we hope is that the lung will develop vasculature and alveoli over a week or two while they're on ECMO. And it usually works, but often not. So what happened here is we took only those babies who'd already been operated on, already looked pretty good, had a honeymoon period, and then deteriorated, which was pulmonary hypertension, and our results were pretty good. Then we started taking other babies who were sicker, then babies with right-sided hernias, then babies with congenital heart disease at the same time. And so nowadays, the hernia babies that go onto ECMO have some profound hypoplasia, and that remains the problem. You can't really tell ahead of time which one is going to recover and which one won't. I'll tell you a little more how we're working on that. With each of these categories, I'll just mention one of the studies that has been done because the clinical research in this area has been fascinating to be involved with. This is the only life support technology in which the endpoint is death that's ever been studied in prospective randomized trials. Interesting when you think about it. There's never been a trial of mechanical ventilation or antibiotics or dialysis for renal failure, but there have been trials for ECMO appropriately because it's invasive and expensive. So this is the study done in the United Kingdom in the middle 90s, mostly at Leicester and a couple other hospitals, in which they randomized babies with severe neonatal respiratory failure and wound up with 41 versus 72% in those groups, which pretty much proved the value of the technology in that age group. These are pediatric respiratory cases, and it's been slowly increasing over the years. If you work in your unit, you know that respiratory failure in babies is common, in adults it's common, in children it's pretty rare. And there are all sorts of causes of it. These are the survival rates for children with respiratory failure, mostly viral pneumonia, bacterial pneumonia, and then aspiration. Children will aspirate anything, as you probably know. So it's a mixed bag, and they go from 25 days old up until 18 years old. So the way to study this is in a matched pairs trial. In 1991, Tim Timmons did this study where they collected data from 32 pediatric ICUs, a whole lot of patients who were pretty sick. The survival rate was only 48%. And they did a multivariate analysis to see which things correlated with success or failure. And the significant things are shown here. The sicker the baby was, or the sicker the child was, the less chance of survival. And the only treatment intervention that had any relationship to outcome was ECMO, and it looked pretty good. So they took the 53 ECMO cases and matched them to similar cases for age, diagnosis, and so on in the rest of the database, and found these results, which was statistically convincing and didn't require randomizing patients to one arm or the other of a fatal condition. These are the adult respiratory cases. Now, the pediatric data is quite complete. This data probably represents about half or a little more of the cases done around the world, but you see that it was only 100 or 200 cases a year until 2009, and that's when the flu epidemic hit, and I know you all had patients with that problem, as we did too, and so that really aroused the interest for ECMO for adult respiratory failure. This is the survival by diagnosis. Not many patients in each group, so that's why it bounces around so much, but it runs about 50%. The same group in Leicester in England conducted this trial, the so-called CESAR trial. If you work in this area, you've read this paper several times. It's a little controversial, but they set it up the same way as the neonatal trial. They randomized patients in different ICUs all over England and Scotland to stay where they were and get the best treatment available there, or to go to Leicester and get treated there with an algorithm that included ECMO if they needed it, which about 70% of the patients did. These are the results of the trial. This is the Kaplan-Meier curve, and so that reached statistical significance for their endpoint, and they stopped the trial early for efficacy. They mentioned in 2009 we had this incredible viral flu epidemic. all of you who were involved about it with these patients know that they were mostly young people, less than 40. They got sick in hours of time. They'd be well in the morning, dying in the evening, mostly respiratory, and it was just a ferocious virus. Now, really, it's no different than our annual flu epidemic, and we all have this every year, but this one caught the attention of the media. Remember, it was the swine flu, and it got a lot of attention everywhere in the world. It hit in the lower hemisphere before it hit here, so the people in Australia and New Zealand had experience with this 6 months before those of us in the northern hemisphere. And they were very good at collecting their data and very good at triaging the patients. So in just a few months of time, they collected all this information. They had 201 ARDS cases of H1N1 flu that had failed other treatment and were transferred to ECMO centers. So there were 15 ECMO centers. 68 of those patients didn't get better. Now, the other 140 or so did. So these are good centers. They took good care of those patients. But the ones that were not improving went on to ECMO. The average patient had been on the ventilator for 2 days, was pretty sick, and 77% of those patients survived. Quite unusual even for ECMO centers. This was published very promptly in the Journal of American Medical Association, so everyone else read it, and the countries in the northern hemisphere set up ECMO teams and triage programs and so on to deal with this. So there was a lot of interest. The results were similar everywhere in the world. I know you had several patients here. One of them was a woman from Scotland who the beds in the UK were all filled up, so she got transferred here, got wonderful care, got better and went home. But that made big news in the BBC. Why don't we have an ECMO bed? We had to send this lady all the way to Sweden to get treated, and so on. At any rate, it raised a lot of interest around the world, and so the interest in adult type of cases with respiratory failure is at a fairly high level now. We also use this for cardiac support, and I told you that's now the most common usage for cardiac support in children. These are the cardiac cases under 16 years of age, and the diagnoses are mostly are congenital defects post-op or pre-op, but also these other things that can cause heart failure in children. And in adults, the data here is not very complete, but the application to adults with acute cardiogenic shock, for example, are pretty good, and you can see the survival rate for adults. Most of it is myocardial infarction. Survival rate's not so good because someone who's had a prolonged cardiac arrest is apt to have brain damage, and the cause of failure here is likely brain damage. So that's for present. That's where we stand. A membrane lung, this is just one of them, transfers carbon dioxide much better than oxygen. So with very little blood flow, you can blow off a lot of CO2, and the patient is on the ventilator mostly to blow off CO2. So this particular company got marketing this product to use on an AV fistula with low blood flow to remove CO2. It works very well for that. It's not very good for something like ARDS, but for asthma, for example, it's a good approach. But that company and others developed new membrane lungs. The one that has the most of the market now around the world is a company called Mackay. They make this membrane lung. They call it the Quadrox. The important thing is it's very low resistance to blood flow, unlike the device that we've been using for the last 30 years. It's very easy to prime. It is kind to blood rather than sucking up platelets like the older lungs used to do. So switching to this membrane lung made a lot of things possible. Much less heparin, much less problem with bleeding and clotting, and the use of centrifugal pumps, which in the past really couldn't be used because the resistance in the membrane lung was so high. But both the Mackay company and the Levitronics company and others make pumps following the design of a German engineer named Mendler, who pointed out that if you put a hole in the middle of the rotor, then you eliminate the stagnation and thrombosis and heat problems that occur with conventional centrifugal pumps. So the newer systems, what we now call ECMO 2, what I call ECMO 2, is much simpler pumps, much better oxygenators, much better methods of vascular access. So what used to look like that now looks something like this, and the ECMO machine in your unit looks as simple as this, and it's made a huge difference in the practice. I happened to be in Melbourne at the time of their flu epidemic, and they were using what we would now call ECMO 2. And here was a patient who had been on this hookup for about 20 days. The nurse is having a snooze. The doctors are doing something else. It's got to be so easy that you just hook it up and let it run, and it's not nearly as complicated as it used to be. So here's another Sweden picture. So when I was visiting here, I've looked this up. It was 1997, and Polly had been telling us since he got the program going here and so on. I wake these patients up. I think they do better if they're awake and breathing and so on. I said, these people are too sick. You can't wake them up. I mean, gosh, they need to be paralyzed on a ventilator and everything. No, I really. I said, well, I don't know. That's just Polly. He's enthusiastic about everything. And then I was visiting here in 1997. Here I am, and I was playing Nintendo with this little boy who'd been on ECMO for 10 days at the time, something like that. And, of course, he was right. And now the rest of the world is slowly learning what you have seen for the last 15 years or so, that once you get through those first couple of days, if you can get these patients awake and breathing spontaneously, extubated or trached, then they do much better. And I really think it's one of the reasons why your results are the best in the world. We're just learning from you that this is what we should all be doing. Here's an adult patient who's not only extubated but up walking around with a double lumen catheter on VV ECMO. He's waiting for his lung transplant. This is Chuck Hoop's patient from a few years ago. But now there have been about 60 patients like this who are children or adults hooked up to the device, out of bed, exercising, bridging to transplant or bridging to recovery. So this algorithm has changed a little bit. It used to be that if we had no improvement with other technology, we would go on to bypass, stabilize physiology, and then evaluate the patient and make a decision, and either the heart or lung recovered in a few days or we turned it off. Now this is all new. So we can decide what the problem is and stay with extracorporeal support for a much longer period of time, and if need be, move to mechanical replacement, that is the implantable artificial lung or LVAD, and then if the organ doesn't recover despite that, then go on to transplantation. So this has all happened in the last 5 or 10 years. It really gives us a clue as to where this is going in the future. So finally, what are we working on? We've learned a lot about these other areas, things that we didn't know before about lung physiology or lung injury and its recovery and clinical trials and fatal illness. One project in our laboratory for the last 15 years has been the implantable artificial lung. If we can do this with a lung on a cart, couldn't we put it in the patient or at least on the patient? And our group and a group in Japan have been working on this for quite a long time. And this has now become clinical reality. This is the first successful patient, a young woman in Regensburg, Germany. And this membrane lung is hooked up to her left atrium and pulmonary artery. It's being perfused by her right ventricle. And after 5 weeks of this, she's on her way to Munich to get her lung transplant, which was successful. And there have now been a lot of these patients around the world. I mentioned diaphragmatic hernia. This is the problem, a little hypoplastic lung on the side of the hernia, but the opposite lung is also very hypoplastic. It just never has room to develop in the chest because all the abdominal viscera are in the chest. And this baby's on VA ECMO, as you can see. You can see the lungs here because we've filled them up with a radio-opaque liquid. This is perfluorocarbon or perflubron, if you've used some of this stuff in the past. And one of the things we're investigating with this material is that if you put this in these lungs and then hold a pressure of about 10 to 20 centimeters of water, would it make the lungs grow? Because that's why they don't grow in utero in this condition, and in fact, they do. So Ron Herschel, who heads up our program in this area, is just completing a series of studies in this, but we think we'll be able to induce lung growth in diaphragmatic hernia using an inert liquid, fluorocarbon. In the very early days, we put some very premature infants on ECMO, and most of them died of intracranial bleeding. So we said we shouldn't do that, and we stopped doing it. Then about 10 years ago, we said, well, let's cautiously go back into this, and we found that indeed you can put preemies on if they're near term. But that got us thinking about the problem of prematurity. All those newborn infants that you all put on and we put on, that's a pretty small group of babies with respiratory failure in the newborn period. Most of them are little 600-800 gram preemies that just don't have enough lung to survive. So we thought, why don't we use ECMO to maintain the fetal circulation? What we currently do is try to put it in, intubate them in 100% oxygen, try to reverse the fetal circulation. Why don't we just keep it in the fetal circulation until the lungs recovered? So we're doing that in fetal lambs, draining blood from the right atrium, reinfusing into the umbilical vein, and it works. So we can do this for about 3 days now. Of course, these babies don't have to breathe. We simulate the amniotic fluid by having them underwater. And we think this will perhaps be a way to explore respiratory failure of extremely premature infants. So in the future, where will we be? Well, this is my slide from 205, which I later updated. So we talked about modular systems for cardiac, respiratory, renal failure, liver failure, and sepsis to plug into the extracorporeal system. And we're now pretty much there. The last thing is sepsis, and that's on the way. New low-resistance membrane lungs, we've done that, and we've simplified it to the point where you can pretty much kick it under the bed. Now, I've just had a chance to look at your beautiful new ECMO ICU, which will be the biggest and the first dedicated ECMO ICU in the world. Your current unit is that, but this one is absolutely beautiful. And there's a great advantage in having all those patients, children and adults, in the same place with a team, most of you who are so good at this that you can manage those patients perfectly, and that's why you get such great results. Most big hospitals won't be able to build an ECMO ICU, or the person who wants to do ECMO is the adult pulmonologist or the pediatric cardiac surgeon or the neonatal person, and they don't talk to each other, they don't necessarily like each other, and they're never going to build one big ECMO unit. So a challenge is how to make ECMO available to all those patients in diverse disciplines in a given hospital, and that's where this comes from. This new system is simple enough that people with moderate experience can hook it up and run it. They won't have results that are as good as yours, but at least they'll be able to get involved and started into it. So that's now happening. So what's happening in the future is this artificial placenta I've been telling you about, using ECMO in the emergency room for resuscitation, which is being done in several places, the implantable artificial lung. Be able to do this without systemic anticoagulation is not too far away, and actually growing organs on ECMO that's way far away, but that's what we're working on. So that's the kind of summary of how we got here and what's happening now. I'd be glad to answer any questions you might have. And again, congratulations to all of you, the best ECMO team in the world. Here you are.
Thank you for a nice lecture, Bob.
Thank you.
Could you please tell us something more about the no anticoagulation thoughts?
This has been a dream of everyone who works in artificial organs research for 50 years, and And we have developed systems that approach that. The best of those came from Sweden. It's the Carmeta system, which basically bonds heparin to the surfaces, and it works quite well, but it does not solve the problem. As you probably know, you still have to heparinize the patient. And the reason why the heparin bonded systems fail is because of the fact that the real problem is not fibrin formation, it's the platelet. So when you expose blood to plastic, the first thing that happens is some proteins get settled on the surface, and within seconds, platelets get attracted there and stick there. They get activated, they attract other platelets. That makes a little platelet thrombus, that makes a clot, and that's the problem. So if we do know that if you give a drug that really inhibits platelet function totally, like a big dose of Plavix, no problem, you don't have to give any anticoagulation, but the patients all bleed like crazy because the platelets have to work when they get back in the patient. So what we've been working on for the last several years is to make plastic surfaces that secrete nitric oxide. The normal endothelium secretes nitric oxide, and it controls vasospasm and things like that, but it also prevents platelets from sticking to the surface. So whenever a platelet gets near the surface of your blood vessel, it won't stick there because it's inhibited by nitric oxide. But as soon as that platelet gets back in the circulation, it works again. So we've been working on that principle and have this working pretty well now. So we can make plastic that secretes nitric oxide at a rate that's similar to the normal endothelium for days or weeks at a time. And so we're 5 years away from having that surface that we think will eliminate the need for anticoagulation.
Is that your group in Michigan?
It is, yes.
Can I have one more question?
Sure.
What about trauma? What about the trend in the United States?
Well, ECMO is very useful for the trauma patient who's exsanguinating. Has not been used very often, but because you have to mobilize it and get it ready at the time the injury and the patient goes to the operating room. But it doesn't happen very often, but in the patient who has a ruptured aorta, ruptured vena cava, ruptured liver, for example, who's just exsanguinating faster than you can fix it by packing in the things that we as trauma surgeons do, going on to ECMO is a reasonable thing to do. And there are case reports of 10 cases here, 20 cases there, not a lot. But, and you might say the person's bleeding, why would you want to put them on ECMO and heparinize them and so on? But what you can do is put them on VA ECMO to support the heart and then cool all the way down. And then when you're down to a very low temperature, patient's essentially exsanguinated, you turn it off, and it's like cardiac surgeons do every day, doing an operation under deep hypothermia. Then you can repair the aorta, take the liver out, fix it on the back bench, do whatever, and then, and most importantly, warm the patient back up again with the ECMO machine and put the blood back in. As you know, if you're a trauma surgeon, when you do this, the reason those people die is not because they bleed to death, it's because they get too cold and they fibrillate and when they get below 30 degrees. And so that avoids that problem.
Thank you.
Rob, could you develop the controversy between VV ECMO and VA ECMO? Like I've told you, I'm very interested in that. I mean, if you listen, at the ELSO meeting, for example, at Keystone, every American being there said, we don't need VA ECMO. I'm a little provocative here, but I have a hard time to agree.
No, it's a very important topic. First of all, VV ECMO, as you all know, you would only use for respiratory failure, pure respiratory failure. But that happens a lot, and you can support the patient using VV support as long as their hemodynamics are adequate. And there may be some slight advantages compared to VA. At least you don't have to access an artery to do it. And I and others used to say that if the patient is failing on VV ECMO, it's because they have pulmonary hypertension, right heart failure, and those lungs are irreversibly damaged. There's no way out of it. You might as well stop. And I used to stop, just turn patients off. Then I learned from you that you know what I mean? You don't have to do that. You can switch to VA and support the right heart, and what do you know? The lung gets better. It's amazing. So we've learned that from you in your group in the last 10 years or so. So it's an important lesson. What constitutes irreversible lung failure has changed totally in the last 20 years because of ECMO. Because we used to say, okay, this lung doesn't work at all, it's never going to get better. Well, it did get better after 2 days or 10 days, or now, what's your longest one? Probably maybe 2 months of time now? Yeah, I mean, amazing. We never would have thought that in the past, but that's going to have to require going to VA ECMO when the pulmonary hypertension gets too high.
Thank you, Dr. Bartlett, for an excellent lecture. I have a little bit thoughts about the new survivors of the congenital diaphragmatic hernias, and what are your thoughts about that, and how should we limit the indications of extracorporeal treatment in those patients?
It's a great question because now it's such a problem. So with those babies with diaphragmatic hernia that have profound hypoplasia, even if you get them off ECMO after a month or a month and a half of time, they still have small lungs with high pulmonary vascular resistance. So I see you all say, oh yeah, we see that all the time. Because so those babies are still very sick. And you know, they're on the world supply of Viagra to try to open up their pulmonary vessels, and we're doing all these things, and they're still in the hospital for 2 or 3 more months of time. It's a real problem. And then even later on, you know, when they get home, they're still on oxygen, they're still very limited. And you know, so we should all wonder, what are we doing here? Have we done any good for this child or for this family? But what we have found is that in a year or 2 or 3, they're normal, healthy children. Amazing. I mean, who would have thought that would happen? But it does. So it's worth going through the effort. And that's why we're investigating trying to induce that lung growth early, so we don't have the 2 years of time. But I'm sure you've all seen some of your own patients who were diaphragmatic hernias. You finally sent them home after 6 months in the hospital, and you thought, why did we do this? 3 years later, they're normal, healthy children. And that's usually the case, so it's worth doing. Not so with Norwood operations. So I don't know if anyone here is doing peds cardiac surgery, but the Norwood procedure for hypoplastic left heart is an operation that works, but it's 3 different operations over a couple of years of time. Many of those children need ECMO to get through 1 or more of those operations, but the mortality rate at home is very high 2 or 3 years later. So that's a condition where that's a real worry. Should we be doing this, or should we just be, if we're going to do anything for those children, should we transplant them right in the newborn period? There's controversy for you.
Thank you for this brilliant presentation. My question is, what do you think it's the role of ECMO in ARDS patients? I mean, in the future, because initially it was a rescue therapy, but now it's changing the situation. What's your opinion about it? Yeah.
Yes. How many of you work with adult ARDS patients regularly? Oh, most of you. This is okay, good. It's an interesting area. That's really kind of my major interest. We started out with neonates, but I've been focused on adult respiratory failure, and I'm part of the NIH ARDSnet, which is a group that does randomized trials in ARDS. So if you ask that question, you're going to get a half-hour discussion wherever you are, not from me. But what's interesting is, just take the ARDSnet. The mortality for ARDS is 30%. It has not changed in the last 15 years that those studies have been going on. These are supposedly very good centers. We're one of them, taking good care of patients. But 1 in 3 patients who just has the diagnosis of ARDS dies. I mean, isn't that amazing? But we've all said, well, look, it used to be 50%. Now we're down to 30. Isn't this good? It's not good. I mean, imagine if you have this, and those are the patients with no comorbidities. In the ARDSNet, if you take all the patients, the mortality is actually 45%, and then you take out the burns and the other obese people and stuff. So it's a big problem. We have not solved it. We're much better at it. It's just like neonatology 25 years ago. We finally learned that beating the heck out of the lungs with high pressure, high ventilation, high pressure, high oxygen ventilation is injurious to the lung. So now we have protocols to try to stop doing that, but the mortality is still 30%. The reason, in my opinion, is that we're using the wrong protocols. It's partly my fault because I was an author on this paper, but the only thing that ever came out of the ARDSNet that's any good is to say, don't beat up the lung, but the conclusion of the paper was use a small tidal volume. That was not justified by the data. Use low pressure. It should have been the conclusion, but everyone's happened on this 6 mLs per kilogram tidal volume, which was never proven to be any good at all. Only if you really bang the lung, it's bad for it. So, quick answer. I ran a big ICU for many years. I don't do it now. But we have always used pressure-limited ventilation, never went over a pressure 35, then 30, then about 25 is the maximum pressure now using pressure-controlled ventilation, and our mortality for ARDS was 15%. Now, what do you make of that, except that if you look at the ARDSNet data, there are still patients who are ventilated at 35, 40 centimeters of pressure. We didn't invent this. Ted Colabo, 30 years ago, said if you go above a pressure of 22, you're going to injure the lung, and he was right. So sooner or later, the ARDSNet or somebody will do the study. Marcello will do it. Luciano will do it. Someone will do the study saying we have these patients. We're never going to go over a pressure of, I now say 25, probably a safe number. And if you have to go over 25, then you go to ECMO. I'd like to see that algorithm work out over time. Inga, what's been give us a little of your experience. I mean, you've seen this, and you've seen everyone else in the world, probably aside from Polly, more than anyone else in this room. How's this evolved for you?
Thank you. Yes, I don't know. We are a small group of us who is still going on with ECMO, and there are a couple of my friends here in the auditorium also, and it has happened a lot, and I think we have more security around the patients, and we have better pumps, and we have learned a lot during this journey, especially about having the patients awake and how to treat the lungs and how to take care and manage the ECMO circuit. So it has happened a lot, but I don't think the journey is finished yet. I think there is a lot of other stuff to develop in the future.
Thank you. Thank you for inviting me, Polly. Thank you all for coming.